అదే.
Hmm. Okay, I think we are live. We can Navina, we can start.
Yes. Good evening, everyone. Welcome to the Higgs Journal Club. Today we are going to speak about pre-hospital high-dose methylprednisolone in resuscitated out-of-hospital
Just hold on,
cardiac
hold on.
arrest patients.
Sorry, we can go ahead.
Yes. So today we have with us Dr. Mahati Priyadarshini from Omega Hospitals and Dr. Gansham sir and Dr. Srinivas sir along with us. Over to you, Dr. Mahati.
Thank you, Dr. Navina. Good evening, Srinivas sir and Gansham sir. Thank you for this opportunity to make this presentation. So, I would just start off with the presentation now. So, as Dr. Navina mentioned, it is about high-dose methylprednisolone in out-of-hospital cardiac arrest patients who resuscitated hospital cardiac arrest cases. So, the source is an intensive care medicine journal. So, out of hospital cardiac arrest are leading cause of death in Europe, is what is mentioned, and the outcomes are nearly 10% successful. The pre hospital interventions like advanced cardiac life support and use of AEDs helped in improving the outcomes. So the study says that people who are unconscious even after resuscitation have a higher risk of mortality. So after a out of hospital cardiac arrest, there is global tissue hypoxia and then a reperfusion injury on achieving ROSC, which triggers immunological cascades, which leads to post cardiac arrest syndrome, which affects both neurological and causes neurological and myocardial dysfunction. So hypoxic ischemic brain injury is the most common cause of death after out of hospital cardiac arrest. So initial treatment of post cardiac arrest syndrome aims to prevent fever in these cases, temperature not being more than 36 degrees centigrade, to achieve hemodynamic stabilization, and to identify the precipitating cause for the cardiac arrest. So interleukin 6, which is a pro-inflammatory cytokine, has been associated with pathological process in post-cardiac arrest syndromes, and it is also a part of development of neurological damage. And as we know, neuron-specific enolase is a guideline-recommended biomarker for neuroprognostication following cardiac arrest and resuscitation. So coming to methylprednisolone, which is a glucocorticoid, has been shown to attenuate the oxidative stress, and it also has potential anti-apoptotic properties. So this study is hypothesized that high-dose methylprednisolone in pre-hospital setting can reduce the inflammatory injury, thus reducing the neurological and myocardial damage which happens. So this study is mainly towards neurological injury which happens in post-cardiac arrest cases. So the aim of the study, steroid treatment as anti-inflammatory and neuroprotective agent following out-of-hospital cardiac arrest, was to assess potential anti-inflammatory and neuroprotective effects of early systemic glucocorticoid treatment. So here methylprednisolone was given in a high doses to prevent neurological damage which happens in out-of-hospital cardiac arrest cases. And this was measured by serial IL-6 levels and neuron-specific enolase levels in patients who survived. So coming to the design and setting, this is a investigator-initiated, randomized, multi-center, blinded, placebo-controlled phase 2 clinical superiority trial. Superiority trial because we are trying to show the superiority of a drug in improving outcomes in the patients. So the participants were from cardiac arrest centers in Denmark, and the enrollment period was of almost 22 months between 10th of October to 15th of 10th October 2020 to 15th July 2022. Inclusion criteria were adults more than 18 years old. The patient should have had a cardiac arrest due to a suspected cardiac etiology. They must have remained unconscious with a GCS of less than 8 following ROSC, and they should have achieved ROSC for at least 5 minutes because the drug was administered only if the patient survived for at least 5 minutes after ROSC. The exclusion criteria were advanced life support, termination of resuscitation exclusion criteria according to the unit's guidelines. Assistole as a first monitored rhythm, women of childbearing potential, known treatment limitations like a previous decision of no resuscitation, known allergy to methylprednisolone, known pre-arrest modified Rankin score ranging from 4 to 5. So the score is from 0 to 5. So 0 being no injury and 0 to 6, sorry, 6 being 0 being no injury and 6 being death. 4 to 5 is moderately severe to severe disability. So temperature below 30 degrees upon randomization and time to ROSC of more than 30 minutes. So following cardiac arrest, they received a standard of care according to the international post-resuscitation guidelines. Temperature was targeted to 36 degrees in comatose patients. Sedation was primarily given with propofol and fentanyl. Vasopressors and inotropes were initiated as needed. All the comatose patients received prophylactic antibiotic in the form of IV piperacillin tazobactam or cefuroxime in case of patients with beta-lactam allergies, and continuous IV insulin infusion in case the patient had hyperglycemia. So the patients were randomized to receive a bolus injection of methylprednisolone in a dose of 250 mg IV or placebo 4 ml of saline, both administered over 5 minutes. The injection of allocated medicine was completed before hospital arrival. So the people involved in pre-hospital scenario were not blinded. The physician and accompanying medical assistants were not blinded. Once they opened the box, they knew which drug they were giving to the patient. So these people were totally excluded from the study following patient's admission in the hospital. So in after hospital arrival, the treating physicians were not aware of which patient received which drug. The co-primary outcomes consisted of daily measurements of IL-6 and NSE from admission until 72 hours. So at 24, 48, and 72 hours. The NSE levels were also analyzed in a subset of patients who remained comatose at hospital arrival, even with people with poor GCS. So secondary outcomes included survival and neurological function at hospital discharge and after 180 days. The anti-inflammatory impact of intervention was further evaluated through measurement of high-sensitive CRP and leukocyte count. Neuroprotective effect was assessed by quantifying neurofilament light chain levels in both the subset of people. For kidney and hepatic injury, the routines were done. The creatinine levels, AST, ALT levels, and bilirubin levels were measured. For coagulation system, plasma fibrinogen was measured. For cardiac protection, TROP-T, TROP-I, and CKMB levels were measured. In the ICU, hemodynamic parameters were monitored, like mean arterial pressure, central venous pressure, main pulmonary artery pressures, pulmonary capillary wedge pressures using a Swan-Ganz catheter, and arterial blood gas analysis were conducted to assess PaO2, carbon dioxide levels, and lactate levels on regular intervals. So safety was assessed by cumulative incidence of adverse events at 180 degrees after randomization. So the patients were followed up to 180 days for assessing the safety of the drug. So the following were considered as adverse events like infection, bleeding, requirement of dialysis, hyperkalemia, or metabolic derangement like hypo or hyperglycemia, cardiac arrhythmia, seizures, and any condition which lead to prolonged hospital stay or death. So the events which caused a prolonged hospital stay or death were considered as serious adverse events. So these are the total number. There were 1,976 out of hospital cardiac arrests over the period of study, that is between 10th October 2020 to July 15, 2022. So out of these, 1,769 were not eligible due to various exclusion criteria, and only 207 were eligible. So out of the 207, another 49 were excluded due to logistic reasons. Probably they say that there was delay in drug delivery, or history could not be taken, initial rhythm was not identified. So due to various these reasons, the 49 were excluded. Remaining 158 were randomized into both the groups, methylprednisolone and placebo group. So there was also post-randomization exclusion in these cases because of various factors like non-clear cardiac etiology, asystole being the first monitored rhythm, more than 30 minutes to ROSC, and not having an appropriate diagnosis for the cardiac arrest. So based on all these, there were exclusions. So in methylprednisolone group, 12 patients were excluded, and in placebo group, 9 patients were excluded. So in methylpred group, 68 patients were analyzed, and in placebo, 69 patients. So these are the baseline characteristics. In these, most of the factors are uniform in both the cases, except hypercholesterolemia, some medical characters, but almost all factors are comparable in both the groups. So coming to primary outcome, the interleukin-6 when assessed in methylprednisolone group, at first 24 hours, there was a significant drop in IL-6 levels. But at 48 hours, there was not much difference. And at 72 hours, the levels were same in both the groups. For neuron-specific enolase, there was no difference in at any point of time in both methylprednisolone and placebo group. So for secondary outcomes, significant treatment by time interaction for high sensitive CRP was seen. So CRP levels were significantly reduced in methylprednisolone group, but NFL levels were not affected at all, like neuron-specific enolase. So in secondary clinical outcomes, the CPC score and the Rankin score were similar in both the groups. So without seeing any superiority in the group in which the drug was administered, even the mortality is comparable in both the groups. Serious adverse effects were also not more with the drug, establishing the safety of the drug. So methylprednisolone did not cause any more serious adverse effects than in the placebo group. So drug safety is established here again. So coming to the discussion, reduction in IL-6 levels after 24 hours was observed. Neuron-specific enolase levels were not affected at all due to because of pre-hospital injection of high-dose methylprednisolone which was given after ROSC. In this trial, a substantial reduction in IL-6 levels was observed in the intervention group 24 hours after admission, but at 72 hours there was no difference. NSC levels were unaffected at all points of time. So there are no pharmacological intervention studies demonstrating reduced NSC levels in resuscitated OHCA, not just methylprednisolone, but to date, none of the trials have established a reduction in NSC levels, which is gold standard of neuroprognostication in patients with brain injury. NSC has a high predictive value for poor outcomes following OHCA, whereas IL-6 has been found to have predictive value for mortality, but no neurological outcomes. So high IL-6 levels cause high mortality. But at the end of the study, even though IL-6 levels were lowered at the first 24 hours, there was no difference in mortality in both the groups. There is presently no substantiated evidence supporting the notion that inhibition of neuroinflammation following OHCA confers therapeutic benefits. So, methylprednisolone, due to its glucocorticoid effects, had its side effects like leukocytosis, hyperglycemia in the intervention group, but it did not increase any mortality. Further increased lactate levels were found in the intervention group, but there was a study done with dexamethasone, which showed that high-dose dexamethasone increased lactate levels, which was directly related to the increased glucose levels. There were in the study they have mentioned that there were previous studies of limited size which showed improved survival and neurological outcome in patients who received glucocorticoids along with vasopressin and in-hospital cardiac arrest. So the clinical study suggested increased rate of ROSC following glucocorticoid and vasopressin injections during cardiopulmonary resuscitation, but there was no difference in mortality. But neurological outcomes were better in this subset of patients. So there was no difference in crude mortality, but there was a lower risk of death with methylprednisolone. Methylprednisolone administered after out-of-hospital cardiac arrest pre-hospital in the used dosage was deemed safe. As we saw, there were some glucocorticoid side effects, but they were not serious adverse effects in both the serious adverse effects, and the adverse effects were comparable in both the groups. So steroid treatment has previously been found harmful after traumatic brain injury, but in this study, it seems to be safe. So coming to the limitations of the study, the co-primary outcomes were assessed using peripheral blood samples. The study group feels that if if the samples were collected from jugular vein, it would have provided more comprehensive insights to the neuroinflammatory process. The sample size was small, so there was a risk of type 2 errors present. So the secondary outcome should be cautiously interpreted, though there were not significant difference in both the groups, even in secondary outcomes. There was also a risk of selection bias because the exclusion of patients happened post randomization. But because they had to reach a sample size of 120, but they included 156 patients because they expected a part of patients to be excluded due to different exclusion criteria. So inclusion of patients in pre-hospital setting is challenging, and several potentially eligible patients were not included due to the logistic issues mentioned previously. In this trial, pre-hospital treatment with single high-dose methylprednisolone injection to resuscitated comatose patients, out of hospital cardiac arrest patients, resulted in reduced IL-6 levels at 24 hours, but did not reduce neuron-specific hemolysis at any point of time since admission. Thank you.
Thank you, Dr. Mahati. We'll take your comments. What do you want? What is your idea about this trial? Hello.
To here, it is I think I have a unstable network. I would cardiac risk cases. Yeah, I would rather the adverse effects of glucocorticoids in these cases because there is no understanding. Just showed that high dose dexamethasone with vasopressin. Addition of known dexamethasone also. So.
Hello. Gansham sir, your take on this trial?
Yeah.
Mahati, we are losing your voice. Probably some issue with your network.
Yes, I don't know why the problem.
Because we are able to hear you in parts.
It's either the network or the microphone. The headphones are not sitting properly. The jack. Okay, Gansham, you can answer. I think by the time that is sorted out.
I think if you look at this particular trial, and now see when you look at the population of patients who are post cardiac arrest, right? We know that universally or kind of most of the data suggests that the outcomes in this subset of patients is not very great. In fact, in this trial itself, you see close to 2,000 patients were actually initially evaluated for cardiac arrest, out of which almost 1,300 patients did not achieve ROSC, right? So even after the achievement of ROSC, when you look at patients who are post cardiac arrest, the survival, second, the neurological outcomes are not very great. Secondly, the number of interventions that are available with us to influence their outcomes are also not. We don't have many of the interventions except for the manipulation of the temperature. I don't think there are any major interventions which have significantly kind of impacted or proven to influence outcomes of patients in a post-cardiac arrest scenario. So in that, keeping that background in mind, I think this trial did try to attempt a very important aspect, which looked at the impact of giving methylprednisolone post-cardiac arrest and to see what happens to the inflammatory markers and the neurological outcomes. Now, over the last few years, our understanding about the pathophysiology post-cardiac arrest has improved. We know that there is something called the post-cardiac arrest syndrome, which is characterized by the immunological response with the release of inflammatory mediators. And I think just like in a lot of other clinical scenarios in intensive care where inflammatory response plays a key role, and the way we have been trying to look at various strategies to modify the inflammatory response and look at whether this is going to have an impact on the outcomes. I think keeping that similar thinking process, when we look at a post-cardiac arrest syndrome and the fact that this is a situation which is associated with a significant increase in the inflammatory mediator, there is obviously a thought process that if you can decrease those inflammatory mediators, can you have an impact on the overall outcomes? But we need to look at the basic difference of whether this is more of a cause versus an effect relationship. Now, if you look at two previous trials, very small trials, where they looked at a combination of methylprednisolone, vasopressin, and epinephrine, where they gave a dose of about 40 milligrams of methylprednisolone, they found that there was a small benefit in terms of neurological outcomes and survival, and that was something which was not kind of duplicated in clinical practice. So yes, from the perspective of the background, I think this trial did try to address a very, very important issue, which we face in our day-to-day life scenarios. But again, it's been, if you look at the results, though the interleukin-6 levels decreased after the first 24 hours, that did not translate into any meaningful neurological outcomes. So will this add anything major? Will this impact the way we are going to look at managing our patients post cardiac arrest? Probably no. Not only the inflammatory response, but if you look at the other aspects of managing post cardiac arrest, be it the manipulation of your hemodynamics or be it the manipulation of the oxygenation targets, I think at least with respect to oxygenation, we have a decent clarity that giving too much of oxygen immediately after post-cardiac arrest is bad. Right? There's good amount of data to suggest that immediate post-cardiac arrest, avoiding hyperoxia is good. With respect to blood pressure targets, again, we don't have very, very clear, guidelines as to what should be the optimal target. The current targets about 65 to 70 seems to be fairly okay. And we all know about the avoidance of fever and avoiding hypothermia. Apart from that, I don't think we have any other interventions which have a significant impact on the outcomes, unless we know what was the cause and kind of try to address that immediately. So that's it.
When I read this trial, sir, my opinion of this trial would be like once you gave methylprednisolone one dose, the IL-6 levels at 24 hours have come down, but that didn't translate into the same decrease in the levels at 48 hours or 72 hours. There was no significant difference, and there was no difference in the levels of NSE. So, as such, we know that the glucocorticoids decrease the anti-inflammatory activity. So there could be a decrease in the IL-6 because it's a systemic systemic marker, whereas NSE is a very neuron-specific marker and more predictive of the good outcomes. So probably the decrease in the anti-inflammatory at the systemic level did not translate into the neuroprotective value of giving methylprednisolone is what I thought. So probably it's only a systemic effect which is decreasing the anti-inflammatory process, but that's not translating into a neuroprotection. Yes, sir. Srinivas, sir?
Actually, the same thing can be observed with the high sensitive CRP levels and the NFL levels. So even there was no CRP came down in the first 24 hours, but again there was no change in NFL levels. So yeah, as you said, it is only systemic effect that was.
So as such, the general effect of glucocorticoids is of the anti-inflammatory effect. So that's what is happening at a systemic level, but it's not translating it into neuroprotection. So the neurobiomarkers that we actually saw in this, like NSE or the neurofilament light chain assay, have not shown any decrease in their levels. Srinivasa, can you hear us?
Yes, I can.
Your opinion, sir?
See, this is essentially, although it set out, my concern about this study is that it set out as a superiority study. It set out to show that steroids will work, will have a better outcome in among patients who have out of hospital cardiac arrest and receive one dose of immunomodulatory dose of a glucocorticoid, and they failed to show the result. So I would look at this study as a negative study, rather than say that. And see, my only other point I would like everyone to understand is that they set out to show it as a superiority study, and in the end, they concluded by saying methylprednisolone is safe. They did not say it is effective. Now, that is when a study concludes something that is beyond the purpose for which it was designed. I don't want to give too much importance to that particular conclusion of the study. As far as the primary outcome was concerned, they failed to show the superiority of methylprednisolone in improving the neurological outcomes among patients who had out of hospital cardiac arrest. Now, this is in a Western situation where transport of patients from the site of arrest to the hospital times are very short, and achievement of ROSC is a quality metric in most of these societies, which we don't have as yet in our practice. So how does it impact my practice? I'm not very clear. When it comes to the biomarkers, single dose of methylprednisolone actually causing a decrement in interleukin 6 levels or non-rise in not no significant rise in interleukin 6 levels is a little surprising for me to accept. And also, I personally feel that serial levels of interleukin 6, when the patient had come out of the effect of the corticosteroid stat dose, should have been a better marker that whether interleukin 6 is the right marker to look at as far as the inflammatory response which affects the brain is concerned for patients who have out of hospital cardiac arrest. So given the scenario, and the fact that it actually brought down the white cell count and did not, there were no temperature spikes, I would be very concerned about extrapolating the results of this study into my practice.
What about the neurofilament chain assay, sir? Neurofilament light chain assay?
So neurofilament light chain assay is one of the biomarkers which has recently emerged as a good biomarker for brain injury. It initially started off as a screening tool and a good predictor of Alzheimer's disease, but subsequently it was realized more than the dendritic damage. If you look at the classification of biomarkers in neuronal injury, there are axonal damage markers, there are dendritic damage markers, there are markers for both, and there are astrocyte damages, interstitial damage markers. So the cellular markers like neuron-specific enolase and the long chain assay, they were considered as good predictors of neuronal death. And in a recent meta-analysis, which looked at a lot of studies, essentially looking at patients with traumatic brain injury, this particular assay was considered to be a sensitive marker for adverse outcomes among patients with moderate to severe brain injury as defined by a GCS of 8 or 12 or less. Ghanshyam's team is actually working on a similar project on brain biomarkers in cardiac arrest and traumatic brain injury. On a similar concept, maybe another 6 to 8 months from now, we may be able to hear from them what they think about neuronal biomarkers. But it's a good marker, and surprisingly, the levels did not show any change despite the non-rise in white cell count and no rise in interleukin 6. There was no difference between the two groups. So are we looking at the right biomarker for out of hospital cardiac arrest, or is there something else? Now, we all know that what kills the brain in out of hospital cardiac arrest is hypoxia, right? And to do that, if you can compare the interleukin 6 levels with a neuronal biomarker plus the brain tissue oximetry by microdialysis, then you can correlate the extent of damage versus the extent of brain tissue oxygen extraction ratio. that may be a little over-invasive in terms of an out-of-hospital cardiac arrest. Maybe if you can actually look at this jugular venous oximetry and then look at the global oxygen extraction ratio, and then look at the neuronal biomarkers, maybe we can say that the extraction ratios have improved, but the neurological outcome has not improved. But biomarkers are going to be the next big thing for triaging and prognosticating patients, at least with traumatic brain injury, and maybe in patients with cardiac arrest, maybe mostly in hospital cardiac arrests.
There were actually some previous trials also, sir, which used some dexamethasone along with vasopressin during the ongoing CPR and also post CPR after the ROSC has been achieved, but they also did not show any benefit in terms of good neurological outcomes.
Yeah.
So, would you
They were
change?
also in hospital cardiac arrest.
Yes,
Sorry?
Maiti, you saying something?
They were also in hospital cardiac arrest, sir.
Yeah. They
This
were.
study
Oh,
is out of cardiac arrest patients. They are in
yeah.
hospital cardiac arrest. So definitely, witness tests have better prognosis and done by professional people. More help is there. Probably all those factors are also part of outcome rather than only being.
Yeah, I think the time to initiation of CPR, the time to initiation of CPR is an as good marker of neurological recovery as the time to restoration of spontaneous circulation. So when did the patient arrest and when the CPR was initiated, that time is as comparable to the ROSC time for neuroprognostication. So agreed that in-hospital cardiac arrest patients tend to do better than out-of-hospital cardiac arrest. But I think the focus in this paper was OHCA in an ambulance-based retrieval system. That may not be true for our practice.
And they have
So again,
actually excluded patients with asystole, sir. And
Yeah, that's part of most of the cardiac arrest trials. They have looked at VF, pulseless VTAC rather than asystole and PEA. So some kind of perfusing rhythm, some kind of cardiac activity has always been the inclusion criteria for most studies on cardiac arrest. Ghanshyam, you are saying something?
no, I think most of the trials which have looked at adding steroids try to focus on the pathophysiological manipulation. The fact that there is something called as a post-cardiac arrest syndrome, there is activation of your immune system, there is a release of inflammatory mediators, and there's a thought process that if you can alter that, manipulate that, or if you can decrease the inflammatory response, maybe you can have an effect on the overall neurological outcomes. I think there was also one trial where they looked at the use of tocilizumab, which is a specific IL-6 blocker, right? Even that trial, which is specifically looking at blocking the interleukin-6, did not translate into any meaningful neurological outcomes. So I'm not sure whether, just like in other cases like sepsis, where we have tried to manipulate the inflammatory response significantly in neurological injury, in neurological patients called post-cardiac arrest, will that lead to better outcomes? Probably, as Srinivas said and as Maiti said, I think the key factors would again be whether it's going to be a witness or a not witness cardiac arrest, what would be the time to initiate CPR, how early, and your temperature management. Probably these things are going to be key.
So actually, even in the pathophysiological process of the HIE that we see, hypoxic ischemic encephalopathy, we do still think that there is a place for inflammation that is causing the damage through hypoxia. But cutting down this inflammation through the administration of glucocorticoids actually did not translate into better outcomes. So maybe modifying some other factors is probably a better thing than meddling with the inflammatory factors, sir.
The inflammatory cascade is a fantastic cascade. It has beaten scientists for the last 60 years. It will continue to beat us, right? We haven't overcome it in sepsis. We haven't overcome it in post-cardiopulmonary bypass syndromes. we haven't overcome it in births. So it is very naive and innocent on our part to believe that we will overcome it in cardiac arrest. But if we can identify the right time where some of these markers are spiking, and we can identify the right molecule which can blunt the action of these markers, we will be able to reverse this process. I think with the availability of machine learning and AI platforms, and phenotyping most of the diseases. Now you have phenotypes of AKI, phenotypes of ARDS, you have phenotypes of sepsis, you have phenotypes of traumatic brain injury. Soon, I'm sure in a year's time or a couple of years' time, we'll have phenotypes of cardiac arrest. And that particular phenotype, which is a hyperinflammatory phenotype, you can identify the timeline where the inflammatory response is kicking in. There, we might be able to use even a cytokine adsorbent column, for example, may have to be considered in such patients, provided we are able to identify who is fitting into which phenotype of cardiac arrest. I think that's going to be the future of resuscitation for all this. There cannot be one size and one prescription for all patients. It's going to be individualized prescription for different categories and phenotypes of patients.
Are we doing this? Yes, sir?
I was about to just I was about to just talk about the same thing that Srinivas has said. I think even in patients with a post cardiac arrest, probably we will be able to identify subset of patients who are likely to benefit with certain anti-inflammatory interventions or immunological interventions. But are we there yet where we have identified these subsets? I'm not very sure.
Do we have centers
Sir,
that
would extracorporeal filters, sorry.
Mahati, we are not able to hear
Am
you.
I audible?
Your voice is breaking, Dr. Mahati.
I type my question in the chat. I'll just type it in the chat.
Mahati, if I'm not wrong, I think you want to know if there would be any role of extracorporeal intervention, isn't it?
Yes. For the cytokines or...
Yeah, so that's exactly what I'm trying to say. We don't know which cytokine is actually the most potent neuronal damaging cytokine as yet. We don't know. We need to work on it to identify which one is the most damaging and at what temporal point of time it spikes among patients with cardiac arrest. Once you know that, we can find an adsorbent column or a filtration mechanism by which it can be removed. So as of now, I don't think we have hit it yet. Although there are people who are showing high levels of IL-6, there are some people who have shown high levels of interferon gamma. There are people who have shown a correlation between IFN and neuron-specific enolase, but nothing has been shown that if you can modulate the levels of the known biomarkers of inflammation or the inflammatory cytokines, your outcomes are going to be better. So I think it will come, but we are not there yet.
Is the mechanism is what is different, which is causing systemic inflammation and neurological inflammation? Because
no, it's not the mechanism. I think the damage which happens to the brain is very similar to the damage that happens to your endothelium in patients with sepsis. It is the interplay between the pro and anti-inflammatory cytokines, the imbalance between the pro and anti-inflammatory cytokines, which damages the glycocalyx and causes the leaky capillaries and therefore the multi-organ dysfunction that defines sepsis. A similar process may be happening in the brain. So it cannot be only one molecule which is working. It could be an interplay between a few of them, and the imbalance between this is what is causing the havoc in the neuronal homeostasis. So I believe that's what is probably, I don't know, but this is my conjecture after having understood a little bit of what actually is the pathophysiology of sepsis.
Do you think there could be a role for steroids in the neuroprotective measures that we take post cardiac arrests after coming to the ICU?
Steroids in neurotrauma, steroids in neurocritical care have fallen flat, as I can remember.
They're actually contraindicated in TBI, but when it comes to this...
So see, we should take a little bit of, we should understand a little bit of difference between different types of neuronal injury. Now, broadly put, just like you have high output cardiogenic shock and a low output cardiogenic shock, you have a warm peripheral vasodilatation in sepsis and vasoconstriction in sepsis. You might have a situation where your neuronal injury is with a preserved autoregulation and a deranged autoregulation. When you have patients with ischemic stroke, or when you have a patient with subarachnoid hemorrhage, or a patient with meningitis, or somebody with the out of hospital cardiac arrest, the autoregulation is not badly deranged. Whereas in a patient with traumatic brain injury, the autoregulation is damaged from the outset. If you look at moderate to severe traumatic brain injury. So these two a priori subsets of patients may behave differently as far as steroids are concerned. But steroids have failed in trauma, steroids have failed in ischemic stroke, steroids have failed in subarachnoid hemorrhage, they have failed in meningitis and encephalitis, except in a small subset of patients with strep pneumonia and H influenza meningitis, where the incidence of auditory loss, hearing loss, and hydrocephalus is less in some Western population where steroids are used. That's a very, very small outliers who get benefit. But methylprednisolone in the dose which has been discussed in this study has failed in traumatic brain injury, has failed in subarachnoid hemorrhage. Spinal cord injury is again a very controversial area. The NASCIS 1, NASCIS 2 have not shown any major advantage. The NASCIS 3 seems to suggest that if the patient with a severe spinal cord injury presents to your ICU or to emergency room within 3 hours after the onset, after the injury, he may have a benefit with methylprednisolone, and with every passing hour, the benefit wanes by about 12 to 14%. This is what the NASCIS 3 trial tried to show. I'm not very sure. Neurosurgeons vouch for it. Intensivists don't vouch for it. The match is still on. So, I'm not really convinced that steroids are the solution to most of these problems in the brain. Let us also not accept that steroids are the only way in which immunomodulation can be done. And as Ghanshyam said, tocilizumab has been used, right? I'm not convinced it worked in COVID either. But still, tocilizumab has also been used. Rituximab has also been used. Rituximab has been used in ischemic stroke, in malignant MCI infarctions with no benefit. So there may be a role for the pro and anti-inflammatory imbalance as the pathophysiological mechanism, but I'm not convinced that steroids are the way to neutralize that imbalance or bring balance back into that imbalance.
Are there any
Yes, sir,
trials?
Naveen.
Yes, sir.
Yeah. No, just to kind of add to what she said. See, if you look at ARDS, again, a disease condition where we know that inflammatory mediators play a major role in the pathophysiology as well as the outcome. Again, steroids were, COVID, we got fantastic results with steroids. And in fact, in COVID-related ARDS, it became the
I think
one of
that's
the
why
key
it's being extrapolated into every other. This thing is what my
So if you look at
opinion.
again H1N1 ARDS, H1N1
No,
ARDS.
Navina, the steroid which worked in COVID was not methylprednisolone. Remember that.
No, with respect to H1N1 ARDS, again COVID had a bad outcome.
Steroids,
right?
Steroids,
Yeah, sorry, steroids. Steroids had bad outcome with H1N1 ARDS. Now, when you commit COVID-related ARDS, steroids had a very good outcome. So, though in both the conditions, the background was an inflammatory response, but the way patients responded to a similar interventions, the outcomes were drastically different. So, are we going to have, or will we be able to identify patients with cardiac arrest who might benefit with steroids? We still don't know.
So, Navina, the point which Ghanshyam is making again has to be understood from the principle that the subcategory or the subgroup of patients who actually benefited from steroids in COVID read viral pneumonia were the hyperinflammatory phenotype of infections, and the cutoff and the molecule they used was not very flashy. They used CRP to tell us whether this is a hyperinflammatory phenotype or a non-hyperinflammatory phenotype, and they use a cutoff of 150 to identify this subset. So which is the marker which is going to tell you that this is a hyperinflammatory phenotype of cardiac arrest which will benefit with steroid, is what we need to understand. And in COVID, the steroid which showed benefit was dexamethasone in a dose which is not comparable to the methylprednisolone dose which has been used in the Sterohca trial. Right? If you use milligram for milligram, it comes to just less than 60 milligrams or 80 milligrams of methylprednisolone, which was not what was used in this study. So using such a high dose, the other side of the story is what would have happened if they had used a smaller dose of methylprednisolone? Has there been a negation of the benefit of steroids with the use of a very high dose, which has caused some metabolic disturbances? We don't know. They haven't declared it. And we can't see it in the results that there was hyperglycemia or whatever the other complications of.
They have mentioned
And
that there were hyperglycemia and also increased leukocytic counts.
Which is again a bad thing. Hyperglycemia is something which
bad.
we all know that it's not good for the brain recovery.
Yeah, and so and just one dose, I felt it was half-hearted. It was a half-hearted attempt. One dose of methylprednisolone is just like one dose of antibiotic with sepsis. I'm not sure what prompted that one dose of methyl, which is never described in any immunomodulatory regimen. Whether you take it for lupus, you take it for ITP, you take it for whatever immunomodulatory syndrome you're treating, it is never a single dose of methylprednisolone, except for transplant patients at the time of the graft. A single dose of methylpred is never given in that dose. So I don't know what is the rationale. We need to look at the explanation. Maybe Mahati, have you read anything about it in the article that says why the choice? Did they discuss why they used that small single dose of methylpred? Not small, but single dose of methylprednisolone.
So, according to their permitted guidelines, but that is for single dosing. Single dosing can be given only 250 ml. They have not given a reason. Only if there was a difference in 24 hours, 48 hours not happening because the drug is not there. The very serious.
I think both the previous trial which showed small benefit, they used 40 milligrams of methylprednisolone.
Yeah.
Or hydrocortisone 300 milligrams. Fixed dose that we not used.
Yeah.
They have mentioned that this is the maximum dose that can be used in Denmark.
Yeah, that in fact that in Denmark that's the maximum dose.
With the maximum dose, sir. Maximum single dose. For one time it can give only 250 ml, but it is not saying use only.
And another peculiar thing what I observed was that they have put all their patients on either piperacillin tazobactam or cefuroxime. And then they have checked the HSCRP levels, sir. So, I don't know. So, we are using the antibiotics, we are using the
again,
then the
Navina,
IL-6 are bound to come down. IL-6 levels are bound to come down.
If you compare cefuroxime and piperacillin tazobactam, it is like a Maruti 800 and a Mercedes. So,
but that is, we are talking about only patients of cardiac arrest with a suspicious due to cardiac causes, not all the causes.
Yeah, we don't know. I think there are serious methodological issues with this study. Maybe it will trigger a series. I'm only worried that in a country like ours, where our tendency to use steroids, a drop of a hat, is very threshold is very low, and because you are dealing with a condition like a cardiac arrest where you can't do much, the abuse of steroids should not go up because the Sterohca trial said steroids are safe. That is a garb, that is a veil under which we tend to hide and give steroids, saying that kuch nahi hoga, de denge, chalo. Anyway, he's going to die, let's give him steroid. Kind of approach should not come into the practice, showing when people like you and me ask for evidence, people can show the Sterohca trial on your face and say, no, look, Navina, steroids don't do any harm, so please give it. So that should not happen. That's my greatest worry.
The IL-6 levels decreased.
Yes. So I'm worried about that.
Decrease in the IL-6 levels was only at 24 hours. It did not translate at
So
48 and
So
70.
then people would say, why not repeated dose after 24 hours?
So have we done a disservice by discussing this paper is what I'm worried about. More than have we done any service by discussing this paper.
Are we like really quantifying NFL levels in India?
Research centers are doing, but NSE centers are doing, even Ghanshyam's unit is doing NSE levels. Some centers are doing S100 beta also. But units which are researching on Alzheimer's and early onset Parkinson's disease, especially among those who have a strong family history of idiopathic Parkinsonism, are using this as a marker, but it is not for commercial decision-making tools. But NSC, yes. I know of at least 3 other hospitals in Hyderabad which are using NSC. So it is available.
Are there any trials that are doing post cardiac arrest blood purification techniques to remove this anti-inflammatory cytokines and all?
Thankfully, no, not yet.
Mahati, you were saying something?
Sir, I was saying that it already started a superior trial, already biased towards the steroid, right? They ended up establishing safety of the steroid.
Yeah, so that's what I'm saying. So you want to say I'm a good boy. I'm not able to prove that I'm a good boy. End of the day, I'm saying I'm not a bad boy. So it's not the same, you know. See, you want to say I'm a very pious and gentle person. I'm a good boy. I have not been able to prove that. So I am going to prove to you that I'm not harmful. You're not going to see me with the same eyes. It's essentially the same thing. So what I'm trying to emphasize for those who are listening is that when the hypothesis of the study has not been validated by their results, it should be treated as a negative trial. And they did not actually set out to establish the safety of out of hospital of steroids in out of hospital cardiac arrest. They did not. That was not the basis or the parameter on which the strength and the power of the study was based on. So even if they say it is safe, you can't use that safety as your tool or your protection to say that steroids are safe in out of hospital cardiac arrest, because this particular study was not designed, powered to establish the safety of steroids.
See, basically, again, reiterating the same point. See, we are looking at an intervention which will add to improving the outcomes and not just safety, because there are thousands of interventions which are safe. But will those relate or kind of translate into improving the neurological outcomes? Is it what we are looking at? So if that is not translating, just because steroids are not new to us. Steroids, we have been using steroids for the last many years, and we know that they're a fairly safe drug if you have used appropriately. So agree to the point that the superiority which they wanted to show was probably not reflected in the results.
Any closing comments, sir?
Closing comments, Ghanshyam?
I have a last thing.
Yes, Dr. Mahati.
Yeah, sir, why did you say that thank God nobody is doing some extra therapies to reduce the inflammatory effects?
I didn't get the
Would it
question,
be more
Dr. Math.
harmful, you think? You said
Our question is, you said thank God nobody is doing
membrane therapy.
injections.
Thank God. See, the reason why I said thankfully we are not doing is that, first of all, our rationale for doing extracorporeal blood purification in sepsis itself, where we have documented damage being done by IL-6 and endotoxin, has not stood the scrutiny of a big randomized controlled trial, right? If you take out the Euphrates 1 trial and you bring in the Abdomix trial, no study has shown that in non-abdominal sepsis, endotoxin removal has an advantage. Now, interleukin 6 level, interleukin 6 adsorbent with cytosorb has been shown to be of benefit in only one Latin American study of about 100 plus patients, which was industry funded. But still, there may be a place for it in patients who are on rising vasopressors, and you may think, but if you say that we should try extracorporeal blood purification in a patient who is having an out of hospital cardiac arrest, and you know that the earliest you can do is within 3 hours, every patient with cardiac arrest will get a cytosol. And your experience, my experience suggests that at least 50 to 20% of them will come out, even if you don't do anything. If you take care of the basics, don't let them have fever, control their blood sugar, don't allow hyponatremia, do not allow hypoxemia. If you take care of the basics, 15 to 20% of cardiac arrest will come out. And those 15% will be the ones who will be on the cytosorb as well. And the cytosorb will prove they'll prove that cytosorb is effective in these patients. So it will be the use of an expensive investigation which is not based on robust scientific evidence. So unless we can demonstrate interleukin 6 levels very high in probably microdialysis, we cannot say that removing those cytokines is going to be of benefit with an extracorporeal device for patients with hospital cardiac arrest, because cardiac arrest is an emotional situation. Anybody will agree. If you say I can try, want to try this, they will say go ahead. So we should not be lured into that kind of trigger happy practices.
Yeah, the other thing is, see, most of these interventions are looking at systemic, inflammatory mediators. What is happening at the neurological level, we do not know, right? Will they address the higher levels of interleukins in the brain? We don't know. One of the limitations that was cited in this trial was they looked at systemic interleukin 6 and not at the jugular interleukin 6, maybe collecting the blood samples from the jugular vein, which could reflect what was happening within the cerebral circulation. Would that have given some hint? We don't know. So I don't think when you look at an extracorporeal intervention, it would address any of these things which is happening intracranially.
One of the exciting aspects of neuromonitoring that will probably come into bedside in 2 years' time or 3 years' time, I'm not sure, is entropy of the brain. If you can actually measure the activity of the brain by non-invasive method and look at the entropy, what is the irregularity in brain function versus the regularity, how much area of the brain is functioning systematically and the other one is chaotic. If entropy can be measured, and then you say I give steroids and I can reduce the amount of discordant activity in the brain, then we'll have a robust evidence for the use of such potentially dangerous treatments for the management of a common problem which kills a lot of patients.
Interesting, sir.
Closing comments, sir?
Forget me and Ghanshyam and Mahati, Navina. What would you do? Tomorrow on night duty, you escape today. Tomorrow you can't. You will be on night duty tomorrow. Tomorrow, if a patient is brought to your ER with out of hospital cardiac arrest, and people know that you are the moderator for the Sterohca trial done today, if they ask you, Navina, will you use steroid? Will you use or will you not use? Or will you say, I want to check interleukin 6 level and then I will use steroid? What is your take? Forget about me and Ghanshyam. We are very resistant characters. You can't change us so easily. What about you?
I'm somehow biased. I'm not biased using steroids, sir. So I would not use steroids because first of all, the concept and the design and the explanation that they're given for the using steroids is something which is not convincing for me. And the only thing that I would use is if my patient is on dual vasopressors, I can give a shock dose of steroid.
That is a different story, a different ball game. But that is the most escape statement for most intensivists for saying, if my patient is in shock, I'll give steroid. Now it's an easy escape because there is evidence for it.
No, but I would not give steroid per se for out of hospital cardiac arrest.
Would you measure IL-6 levels in your next patient with out of hospital cardiac arrest?
No.
Would you measure CRP in your next patient with out of hospital cardiac arrest?
No. I would rather try to measure NSC probably, which would probably give me a better.
So if the NSC was high, would you give methylprednisolone to your patient?
No, because it didn't show any effect anyways on that.
It is safe. Will you give it?
No.
Okay, so my answers are given by you, so I don't need to answer.
Probably for prognostication.
Sorry, Mahati.
NSC probably for prognostication. NSC we can do probably for prognostication, but not for giving steroids.
Yeah. So I think it's not one biomarker. I think we should need a battery of biomarkers. One by one, we should add. Because neuromonitoring is a very, very exciting and very interesting field. We have done 2 projects on neuromonitoring in the last 2 years, and Ghanshyam is doing one now. So that's it.
I think, as usual, the most I find steroids the most abused kind of group of drugs that are probably being put into every other disease, including every other organ that is coming, sir. Whether it is inflammation or anti-inflammatory, without even like really knowing what is the background of the pathophysiology of that particular disease.
Yeah.
So I think it's too far to say that it will play any role in post-cardiac arrest status.
Don't make such a blanket statement, because next year you may get a study which shows it works and you will be the moderator still. So just say as of now we don't have evidence that steroids work in cardiac arrest, because you will have to retract your statement a year from now if some study comes in. Okay.
I don't think so, sir, because
that's the beauty of critical care.
Because already the places where we are using steroids, they are still controversial too. So somebody with a complete efficiency that steroids will work in this, I don't think so. I'll do that next year.
Yeah, that will be my 10 commandments for next week. Steroids in the eyes.
Okay, I'll be looking forward for it, sir. Thank you, Dr. Mahati. Thank you, Srinivas sir. Thank you, Ghanshyam sir.
Thank you. Before we close, I would like to wish everybody a happy Easter coming up and a good Friday tomorrow, and hope Sunrisers win today.
And yeah, from the whole Hicks community, I think I would like to congratulate Srinivas Samvedam sir for taking over as the president-elect of the ISCCM. Hope to see a lot of changes from you, sir. Congratulations. And see you all.
If steroids don't work here, Navina, I have to fight on my own.
See you all next month, sir.
Bye-bye.
Okay.
Thank you.
Thank you, everybody. Thank you, Mahati.
Thank you, Mahati.
Yeah, thank you for the opportunity, sir.
Well done. Thank you.
Yeah. Good night, sir. Thank you. Thank you, sir.